pox family related to smallpox, cowpox, some others not related to chickenpox. It is a significant illness. It's a disease that's normally found in Western Central Africa. Cases outside of those regions have been very rare internationally. It is in a reservoir of animals in those places in Africa and does spill over into the human population there. So there are cases and outbreaks that occur in Western Central Africa commonly. It is endemic in those areas. But cases outside of there have been very uncommon. I think 2003 in the United States, 2008 in the UK. But in the last week or so, there have been a few dozen cases in Europe and North America. So cases in the UK, in Italy, Spain, Portugal, Sweden, some suspected cases in Canada, and now, as we know, a confirmed case in Australia. The cases that have occurred in Europe have either had a travel relationship with West Africa. This cluster of cases in Europe and North America seems to be related to the West African clade. That is a milder version of this monkeypox virus, but it still has serious case fatality rates. So between 1% and 5% of individuals are reported as dying from that. That is in an African context where significant medical care exists. You would expect it to be lower. That said, there have been, as I say, a few dozen cases across Europe and North America in people who've either travelled to West Africa and also noted in the community of men who have sex with men. That probably relates to the close contact that occurs. So the transmission of the virus can be through the fluids, the material within lesions in those pox. There can also be respiratory transmission for people who are in close contact with each other, so direct transmission through respiratory pathway, or, as I say, that close skin-to-skin contact. The individual who's been diagnosed in Victoria came from London, so flew on the 14th, landed in Abu Dhabi and then was on an Abu Dhabi-Melbourne flight, landing in the early morning of the 16th. Had some symptoms prior to being on the flight, but has attended for medical care almost immediately and had an extremely astute GP who has thought of monkeypox and referred him for testing, which has led to early diagnosis, early isolation. There are very few close contacts that have been identified. Obviously, the GP is one of them. We'll be contacting individuals who are close contacts on the flight, so really in the rows, a couple of rows in front and behind, and then people who are on the entire flight. We are just asking to be aware of the symptoms that might occur. So those symptoms are flu-like symptoms. They can be headache, fever, muscle aches and pains. Generally, people are more unwell than with a mild cold. So it can be quite significant constitutional symptoms, and then a rash occurs with those typical chickenpox-like lesions that occur, so fluid-filled, pus-filled, and Alan Cheng is here, Prof Cheng from the Alfred, to talk a bit more about the clinical presentation. But the flight from Abu Dhabi to Melbourne was EY462 and landed at 0545 on the morning of the 16th. So the risk of transmission of this virus is not great. It is a very rare virus to find outside West Africa. But what we've seen in the last couple of weeks is that more cases have occurred than has been the case historically for a long, long time. That may be a combination of changes to the virus. It may be the fact that we are now further and further away from when we all got vaccinated for smallpox. The smallpox vaccine provides some protection against this virus, and smallpox vaccination finished in most of the world in the 1970s up to 1980. And so that lifelong protection still applies for those of us who are vaccinated, but there are clearly many, many of us born since 1980 who will not have that protection. We do use the vaccine as what we call post-exposure prophylaxis. So for those individuals who've been exposed to monkeypox virus can get the smallpox vaccine after being exposed, and there's a window of 4 days for those individuals to get some protection from the smallpox vaccine. So we're in conversations with the Commonwealth via AHPPC about the national medical stockpile and the use of smallpox vaccine for those individuals who may have been exposed, who are in that window, as well as the potential for vaccinating a small cadre of healthcare workers who might be required at the front line if we get further cases. But I might throw to Alan now just to give a little bit more on the clinical details for this case or cases in general. Thanks, Alan.
Thanks. For us, do we need to be ordering things quickly so, if we get to that point, we don't see a repeat of last time?
We do have a significant stockpile of smallpox vaccine in the National Medical Stockpile, but of course they will reflect on that stock and the size of that stock and the likely forward demand. It's a bit uncertain, obviously, at this stage. I think we can expect some more cases. We've clearly got dozens in Europe, and there's open international travel now between there and here, and indeed North America. I think it's more likely to come from those places than from West Africa itself, but the smallpox vaccine requirements will be really limited to those immediate close contacts of cases.
There'd be a number of Victorians who are looking forward to travelling to Europe over the European summer. Is this something people should be wary of? Is this the kind of virus that could potentially see borders shut like we saw with COVID, or is this something to go about your daily business and just be aware of?
Yeah, I think it's a daily business virus. Clearly, it's a new virus that causes concern in people who are unfamiliar with it, but it is rare to see cases, and the usual precautions. I mean, the wearing of masks, the washing of hands, the things that we shouldn't need another reason to do are things that we should be doing anyway in a COVID world. So I hope that's enough for people, and I certainly wouldn't recommend anyone put their travel plans on hold, and I don't expect any border closures anywhere in the world.
Are there specific segments of the population that this could hit harder than others? Are kids more susceptible, or older people, for instance?
Yeah, look, both kids and older individuals can get more severe illness, but we don't have a long history of this in Western populations, so it's a bit hard to say, but there are many people who are on immunosuppressive therapy or who have significant underlying conditions. That they are usually the ones most at risk of severe illness. So, particular precautions to bear in mind there. But again, it's really awareness of symptoms and awareness that it's in that international arrivals population at the moment where risk is greatest.
Do you think we'll see more cases in Victoria, not necessarily from this case, but also potentially among other return travellers?
Yeah, look, I think it's possible. I think we need to ready ourselves for the possibility. That's why there's been a Chief Health Officer alert put out for clinicians to have awareness of the presentation. So for those people who are presenting with headache, fever, and then a rash developing that looks a bit like chickenpox, with significant lesions across the body and face, they're clinicians that we're hoping refer to emergency departments. The clinician or the individual should call ahead, make sure they wear a mask, make sure they let the emergency department know that they're presenting so that nobody else is potentially exposed. That's the usual advice we give for measles. That's exactly the same advice in this instance.
Professor Cheng said that the man who is currently in the ARFA is in isolation. Is that much the same? Are they much the same isolation requirements, say, for a COVID patient in hospital? What does that look like?
Yeah, basically,
Yeah, look, as we do for many of our notifiable diseases, we ask those close contacts to quarantine. We'll determine exactly who we regard as a close contact, but that's just sensible advice to those people who might be household contacts or intimate partners, etc.
Is that going to be for a full week like COVID at home?
Look, there'll be a specified period. There is an incubation period that can be from 5 days up to 21 days, I think. So there'll be considerations about what exactly the quarantine period should be from a national level. There are conversations happening as we speak.
And when you say, sorry, did I hear you say that the man tested positive? Is it a PCR test?
It is a PCR test, that's right.
So if somebody is deemed a close contact and has to tell their work that they're now a close contact of a monkeypox case,
They don't have to specify anything about why they can't come into work. If they are requiring to quarantine, they shouldn't be going to work. They don't need to test if they are without symptoms. People who are without symptoms should not be seeking a PCR test because it won't tell them anything. But the quarantine period is just in case anyone develops symptoms during that period.
Just on the flu, we're obviously seeing a rising number of people coming down with it. How many people, great if you had these figures, how many people have been hospitalised with the flu so far this year?
I don't have those figures today, I'm sorry, but clearly it's picking up. In the last few weeks, we've seen a really steep rise in the number of confirmed cases of flu, so it's very clear that the season is beginning. That's pretty early for a flu season, and we know why. It's because we haven't had a season the last 2 years, and that susceptible population means that it can just take off a bit faster. The exact numbers hospitalised we'll have to come back to you with, and can provide that offline.
So when do you usually expect the spike in flu hospitalisations to occur?
Yeah, look, often in a routine flu season, you're talking about July to September. So to see an uptick in cases in April, and we don't know what May, June, July will look like. It may continue to be significant right through that period, but it's definitely an early start as seasons go. But it's still, it's still within the bounds of what you kind of see in May during a routine flu season. But we don't need any more pressure on the system, and we don't need people to get an illness that can be severe for those most at risk as well. So kids under 5, pregnant women, Aboriginal and Torres Strait Islanders under 15, over 50, anyone over 65 years of age, anyone with a chronic underlying illness should get the vaccine. Indeed, it's recommended for anyone 6 months of age and above. It's now available through pharmacies for kids over 5 years of age. That's a really positive development. That's a new regulatory change that allows for pharmacists to provide the vaccine for kids over 5. So really there is no excuse in terms of access in getting the flu vaccine, and there's a lot of illness going around now, so don't add that to your list of possibles.
Does waning immunity is that a factor in increase?
Yeah, look, I think lack of natural immunity from not having a season for 2 years is playing its role. We've all been protected from flu seasons almost fully. We had virtually no cases last year, so that does play a role in terms of how it might be playing out now, coming a bit earlier and potentially being a bigger season. And going into winter, more people indoors, lots of respiratory illness around at the moment, as anyone who's got kids in school or friends would be aware of.
And are hospitals reporting that this early uptick in hospitalisations is putting pressure on their resources and staff?
Certainly they're seeing cases who require hospitalisation. When you've got a lot of flu cases, there are going to be a proportion who require ward treatment or indeed intensive care. Those are still relatively small numbers, but it's going to be a long winter season in that regard.
Do you think lighter flu is spreading quicker because people are doing a RAT for COVID, saying I don't have COVID, well then I'm fine and I can just go about my business because it's not COVID?
Yeah, look, I think that's happening a bit. We know from national flu tracking, self-reported data, Flu Tracker, that the vast majority of people with flu-like symptoms are getting COVID RAT tested. That's great, but not many of them are getting tested for flu. And so you shouldn't assume that just because you're RAT negative that you can be out and about. If you've got symptoms, runny nose, sore throat, aches and pains, fever, headache, it could well be flu, along with a whole bunch of other respiratory viruses. They are all transmissible, and you should really isolate until you've recovered from those symptoms. You should also consider going to your GP to get a PCR test that looks at that respiratory panel, tests for flu, tests for other coronaviruses, tests for other cold viruses.
There have been calls from the AMA for mandatory mask rules to be reimposed indoors. What's your view?
So the pandemic orders as they are at the moment are set. Obviously the Minister has opportunities to change those. That's how the call is made. If there's an opportunity for pandemic orders to change and a request for my recommendations, I would provide that.
And what
What
would
are
your
your
recommendation be?
I can't tell you what my recommendations would be until I'm asked. The epidemiology at the moment is clearly challenging. The recommendation has always been please wear a mask in indoor areas. We know that a lot of people are following those recommendations, but we want to continue to encourage people to understand that it's not over, that there's a lot of respiratory transmission going on, not just with COVID, but with RSV, flu, and a whole bunch of other respiratory viruses. And mask wearing indoors is a really, really good idea.
Well, the fact that there's a fair bit of weariness with mask wearing in the community and the decision might be unpopular and the government might not want to be imposing it a few months out from a state election play into your view at all? Or
That's not for my comment. And look, my advice would not take any of that into consideration. They might be considerations for the minister in terms of social licence or the willingness and fatigue of people with respect to mandatory mask wearing. But, you know, our healthcare workers have been wearing masks for 2.5 years. Alan's been wearing a mask for 2.5 years. And people should really think about really what a low impost it is, a bit of fabric on your face to protect yourself, to protect those around you, and to protect the health system. It's a small price to pay.
if you were asked today, what would your advice be in terms of whether or not masks should be?
Look, I would always make the case that mask wearing is going to be a downward pressure on transmission. With respect to mandates, those are broader considerations and they are entirely for the minister's making.
Would it be accurate to say you are concerned about the rising flu numbers we are seeing, particularly in the last 2 weeks?
Yeah, no one wants a really significant flu season. We've got good numbers of flu vaccine going out the door, so we know that there's decent demand. There probably hasn't been as much demand for kids as we would have liked, and kids are clearly able to transmit it, and kids can also get significant illness with flu. It remains rare, but kids under 5 are a recommended group for a reason, because they do have the potential to experience more significant illness, either respiratory illness, but it can also affect the brain. So getting the vaccine is a really good idea, and absolutely making sure that you're isolating at home as an adult, making sure your kids aren't going to school with significant symptoms remains really important.
How long after a COVID infection can you get the flu shot?
After an infection, you should be recovered from your infection, so you'd need to be well to get your flu shot, but other than that, there's no limit.
Thank you.
All right, thanks for your time.